Today we are going to have a case with the Descemetocele, and here you can see, if you look at this cornea from in front, this eye is half open and you can see ciliary congestion in this area, and that tells you that the area is active. This is ciliary blush, the blood vessels over here, and the most prominent thing which you see is this brownish tissue over here in the center. So this is the area which is very clear over here, and surrounding that you see an area which is less thin over here, and then going around you see a sort of area of a leukoma or scar tissue which is over here surrounding that area, and you've got blood vessels coming into this area. Cornea is usually avascular, and you don't have much of blood supply, so healing comes in from the limbus. But if the ulcer is very away from the cornea, then new vessels tends to grow into the cornea, and they will supply new nutrition to the new blood vessels which have grown. So these new vessels tell you that, number one, that this ulcer is old and it's got a bit of scarring in it as well. And by the look of it, it shows you that it does not have any yellow infiltrate over there. So, but it's got whitish area of scarring over there. So that could be, in a differential diagnosis, you can have herpetic keratitis, a geographic keratitis, producing thinning, descemetocele, and then perforation. That is one differential. The other is if the patient has rheumatoid arthritis, they can have a corneal melting, but with that type of melt, you won't see that whitish scar tissue which you're surrounding in this area. The pupil is as such that when you have it, if this iris prolapse, the pupil will immediately become oval like this over here, and it will bulge outwards through the cornea. And if I take a cut section of the cornea and make it over here, so if this is the area which is thinned out, and you can see this is the cornea, and over here where there's the descemetocele, this area where there's thinning, you can sometimes get a bulge of this area forward. So you would have a descemetocele, like if this is the back part of the cornea and you're coming in like this, the way the descemetocele is, you would have a cornea, a section like this. So I'm bring this over here because I want to show you in the video that comes in that how it looks like this, and when you bring a slit, you will see the slit thin out in the center, and when there's only descemetous membrane, this area, you can see this area is scarred down, so it's all white. But because this area was initially white, but because it's thinned out and it's only descemetous membrane is left over here, it becomes very clear. And the patient usually says at the end, when the ulcer is converting from a descemetocele to an ulcer, that his vision is getting clear, so he gets excited, maybe things are getting better, but actually they are getting worse. And how can you treat this descemetocele? If you've got a descemetocele, one treatment you can do for that to buy time is to get a contact lens which you put into over the cornea in this patient. And this is the patient exactly with that thing on. We'll show you the video in which the contact lens is on the cornea. You can see ciliary congestion over here, and you can see the edge of the contact lens over here, and it's riding over the surface of the bandage contact lens. I'm using a plain forceps to just get hold of that contact lens and remove that over that area, because we wanted to see what is happening and to replace that contact lens, because you can see there's a lot of mucus and pussy material collected on the contact lens because of over the time which has been in place. There's a lot of matting, and this is what we saw initially, that the cornea is thinned out. Obviously, the definitive thing which you'd like to do is control any inflammation or any infection there is, and then plan a tectonic corneal graft in which you would remove that area of the cornea, and then you would go in and place, if you're going to plan for a tectonic graft, then you would go in and replace that area. You would make a trifine sort of a punch over here in this area, getting a healthy area from the surrounding area, and then getting this replaced. But if you wanted to get more of an optical result out of this, then probably you would involve the pupil in this trephine and then make a cut in the cornea like this, so that you have this area which is slightly eccentric to involve the area of the cornea. So this would typically be a tectonic graft, and a tectonic graft is something you would get if you have got availability of donor cornea. Sometimes you've got availability, but sometimes you do not have availability of the cornea. If you unfortunately do not have cornea available in the long term, one option is to go in for an amniotic membrane that acts basically like a basement membrane, and what I say, it's a glorified contact lens and gives you time before that healing occurs. Tarsorrhaphy is one option because the vascularization from the tarsal plate, conj, that gives to this area, and that tends to heal things. And if it's going towards an imminent proliferation, I think one thing that can be done is a conjunctival flap, which is not very recommended if you've got a corneal service and you're able to put tectonic grafts. But conjunctival graft, if you think there's no cornea is going to be available and the eye is going to go blind just by sort of everything coming out of the eye, then you can go in and make a bipedical flap of the conjunctiva. So you would give a cut in the conjunctiva over here, and then give a place over here, and then make a cut over the conjunctiva over here like this. And once you've cut this conjunctiva becomes mobilized, and you can put it as a bucket handle flap over here, and then you can suture it over here in this area. So if I remove this, what will happen is I'm left with a conch which is covering over here, covering from this area to this area, and you would suture that conch flap in place. And ideally, I would like to do a glue tarsorrhaphy, so that gives you more support before that conjunctiva comes off and the conjunctival flap. And so the area which you have cut from the limbus is this area of the conjunctiva, which you moved forward over here. So this is the lower part of the conjunctiva, this goes over here, and the other part which you have over here, which you cut over here, this comes over here. So this is the conjunctiva which is moved as a pedicle forward, and it's got its base over here, and this conjunctiva then moves over to this area, and this one over this area, and we've got a bipedical flap, and this is good, very good results. And then once it's vascularized, then you can go in, and what happens is you can just cut a area of the conjunctiva around it and sort of detach this area and cut it off. You'll just have a small diamond of vascularized area with a conjunctival flap. The mainstay of treatment will remain on what is the main pathology. If it's a viral ulcer, you need to use topical antivirals. You need to also use oral antivirals, and that will help you in healing that ulcer. And the best possible way you can treat this is tectonic graft, but you need to see your resources and your planning. But your main vision is first to save the anatomy of the eye, then the vision of the eye, and then obviously make the eye comfortable for the patient. I think thank you very much for watching, and we look forward to seeing you again.